my name is Dan Roth. I'm a physiatrist and interventional pain management physician in Fort Wayne, Indiana with Summit Pain Management. Today we're going to go over the examination of the lumbar spine. We have our patient here, Tom. One of the first things we want to do when we're looking at examining the low back is, of course, our initial inspection. So one of the things we're going to look at with Tom is kind of decide our midpoint line here and initially look for symmetry. So do you see hypertrophic paraspinal muscles on the left or right? That can give you some clue to some pathology. Is one, just through inspection, iliac crest higher than the other? Is there a shift left to right, or a side bending shift that we see very frequently with a irritated nerve root or pinched nerve root? So these are things we can look at just with a basic inspection of the lumbar spine. Next, we'll go to the palpation of the anatomical landmarks for an appropriate physical exam. So after looking for symmetry, next thing we want to do is palpate some of the anatomical landmarks. So initially what you want to do is find the posterior superior iliac spine, put your hands over the iliac crest, and look for symmetry. Are your thumbs lining up? Are your hands lining up where they should be? Is one a lot higher than the other, a lot lower? That gives you a little bit of an idea of the pelvis and pelvic symmetry or pelvic obliquity. At this point, have the patient bend forward, and then have them come back straight, and then extend backwards. Have them come back straight, side bend to the left, and then side bend to the right. Come back straight. And during the movement, what you want to do is feel the way the patient's pelvis is moving. Pay attention to your thumbs. Are they moving symmetrically in motion together with each other? Is one thumb not moving at all? And this gives you a little more information as to, again, the pelvic symmetry, asymmetry, and the mobility of the patient that you're examining. Next, we'll move on to the palpation of the posterior elements of the lumbar spine. Next, we're going to look at the posterior elements of the lumbar spine, or the facet joints. With the facet joints, there are three things you can do. You can palpate them for tenderness. You can load the facet joints with a physical exam maneuver called the Kemp's maneuver. And the other thing you want to do as you are doing those tests is look for changes in range of motion again. So with the patient, typically I start down low at the L5-S1 level and just palpate and just push. Again, you can feel paraspinal muscle hypertrophy as you go through and you do this, but you can also push and ask the patient, is this tender where I'm pushing? Now, it can be paraspinal muscle pain, but typically what we find is that patients who have acute or chronic back pain can typically have some component of facet disease involved, and so facet arthropathy and facet-mediated pain, if patients are tender as you're palpating up and down the vertebral column where the facet joints live, that gives you a little bit of an indication if that's potentially part of a component of the pain. The other thing you can do is load the facets. So what you would do is just kind of give the patient a little bit of support, ask them to extend and rotate to the left, and then rotate to the right. You can push, give a little bit of push too as they're doing this to help accentuate that. And what you want to do when the patient's doing that is ask them, is this painful? Does this cause pain where you normally hurt? Does this make your back pain worse? Does it make your leg pain worse? And that gives you some information as you're going through that portion of the physical exam. Next, we're going to move on to the assessment of the SI joint. Some of our initial examination looking at pelvic symmetry and asymmetry did include some components that would involve the SI joint, but I'd like to give a little more specific information about evaluation of SI joint pain. So again, with the patient in a standing position, put your fingers over the PSISs and then rest your hand over the iliac crest, and then you have the patient bend forward. Again, you're looking for symmetry with movement here. Is it painful? Do they feel a pull or a stretch in this area? Another exam maneuver called the Stort test also looks for symmetry or shift or movement in the SI joint. So you just have the patient stand on just their right leg and then just their left leg, and you're looking for dropping or movement with your thumbs over the PSISs. At this point, to go to the next portion of the SI joint exam, we're going to put the patient in the supine position. With the patient in the supine position, there are a couple tests we can do to look at SI joint dysfunction as the cause of the pain. First test is called the Patrick's maneuver. In this position, the patient's supine. We take the leg, bend it, and let it kind of fall off to the side in a frog leg position. Stabilize the patient over the ASIS, and then start to push down in this direction like this. A positive sign, you can have a contralateral or a ipsilateral involvement with this test. Typically, as we put the patient in this position and we begin to push, we'll see ipsilateral pain, but contralateral pain can also be present. You would do this test on both sides to assess for symmetry and involvement of both joints. Many times SI joint involvement in acute pain is unilateral. In chronic pain it tends to be more bilateral in terms of involvement. The next test we can do in looking at SI joint pain and dysfunction is a resisted straight leg raise. What you want to do is have the patient bring their leg up about 30 degrees and hold it, and then again you want to stabilize the patient's contralateral leg and have them resist you pushing down. So go ahead and resist. Okay, relax, go ahead and lower your leg. And so you can do that on both sides, but this is a very common test to use for SI joint dysfunction. Pain with this test is typically on the ipsilateral side that you're testing. Next, we're going to move on to the assessment of lumbar radiculopathy. So lumbar radiculopathy involves the nerve roots in the lumbar spine being affected, either in the nature of chemical radiculitis or in the nature of a compressed nerve root. What we want to do when we're assessing for that, one of the most common maneuvers is something called a straight leg raise. What you want to do that if the patient is bring the leg up to approximately between 30 and 60 degrees. When you're in this position, this should elicit some of their common or normal radicular pain. Pain in the back of the thigh or pain in the calf is not consistent with eliciting their typical pain. You'll want them to feel pain in typically all the way into the lumbar spine, and the normal pain sensation they feel in the back of their thigh or their calf. It's just important not to get confused with a muscle stretch versus a true positive straight leg raise. If you perform a straight leg raise and you're unsure if it's positive or not, you can add some neural tension by pulling back a little bit on the foot. So dorsiflex the foot. Again, if the patient feels a stretch in the calf or a stretch in the hamstring, not a positive sign. It has to reproduce their typical radicular pain which they're presenting with in your office. So with our examination of the neurological component of the lumbar spine, again we're looking at 3 levels typically involved: L4, L5, and S1. The L4 reflex is the patellar reflex, so that's fairly simple to test. You should palpate the inferior pole of the patella and then also palpate the tibial tuberosity. As you palpate those, you can kind of create a space to where you hit the tendon, and then again just a motion like this and you can elicit the reflex. You usually test it a few times repetitively, see if we're getting a normal response, and again you want to check side to side for symmetry. The L5 reflex is the medial hamstring reflex. This isn't commonly done, but it can give you a lot of information in the physical exam if you're looking at a isolated L5 radiculopathy. So palpation of that is back here, the tendons of the medial hamstring, and basically you want to hit over your fingers themselves, and you're going to look for flexion here, and you can see the motion in Tom's leg as I'm doing this. It's not a lot of motion, just a little bit of motion. A lot of it too, you can palpate the tension of the muscle or the reflex contraction of the muscle as you are doing that maneuver. Okay? The S1 nerve root is tested with the Achilles tendon. So as you're doing that, again, you can kind of palpate the same way. Another good trick as you're doing this is to palpate at the top of the calcaneus. Give a little bit of dorsiflexion to the foot, and then as you do that, you're going to get a better response. If you palpate with, or if you do the test with the foot in its normal position, and I'll show you this, you probably won't see as good of a response. You can still see it, but it's always better to be able to see it and feel it. So give a little bit of dorsiflexion, and then you can test it. And you can see that with Tom's plantar flexion. Next, we'll move on to the sensation testing. In doing the sensation exam, it's easy to follow the classifications that are set forth when doing an ASIA exam for spinal cord injury. The dermatomes are kind of already set. There is some overlap in dermatomes and some patient irregularity, but when you follow the ASIA system, it tends to be very consistent. So again, L4, L5, S1 are the most important components. So the L4 sensation would be the medial malleolus, and so you can do light touch. You can also do pinprick sensation. L5 would be the skin between the webbing of the first and second digit. You can test there. And S1 would be the lateral malleolus, the skin at that surface. Again, symmetry, side-to-side symmetry is very important. In a lot of lumbar radiculopathies, we don't see a lot of sensory change. Patients will say they feel numbness in that area or tingling in that area, and that may be a component that you would look for when considering radiculopathy as the cause of pain. In the assessment of manual muscle strength, specifically as it relates to lumbar radiculopathy, we want to look mostly at the L4, L5, and S1 components. So L4 primarily will be the leg extensors of the quadriceps. To test L5, ankle dorsiflexion or the EHL, extensor hallucis longus with great toe extension, and S1 would be foot plantar flexion. So initially here, what you want to do with the patient, there's two ways to do this. If you have the patient straighten their leg and hold it there, you can start to push down against them and have them resist that. Okay. The second way to do it would have the patient push against you, and you can do that there. Again, you're looking for symmetry side to side, so you would be testing both sides. So that's L4. L5, have the patient bring their foot up in the air, dorsiflexion, and then resist you pushing down. The other way to do it is have them be in plantar flexion and then start to push up against you and to resist that. The first one that we did, I think, is most reliable. The second thing would be to bring the toe up in the great toe into extension, and then you're pushing just down on the great toe. That's the extensor hallucis longus, and that's an L5 derived muscle. The last component would be plantar flexion, so you can stabilize the patient and have them push down against you, and then you're resisting that. The gastrocsoleus complex is a very strong muscle. Sometimes you're not going to catch small grades of strength change, so the other thing you could do would be something like heel to toe walking, and we can show you what that looks like here. So in the assessment of the L5 and S1 nerve roots and muscle groups, if you've done your manual muscle test and you can't find any discrepancy but you think there may be weakness, you can have the patient do heel to toe walking. So Tom here will show the heel walking first. So he'll walk with his foot in a dorsiflexed position. Go ahead, Tom. This is an assessment of the, again, L5, primarily nerve root. Patients who can't perform this or have weakness with that may have a half a grade strength deficit. So we can also show this in toe walking, so forward toe walking, so Tom's up on his toes, walking that way. Again, another test for the S1 nerve root and the gastroc strength. Patients, again, who may have balance issues or things like that, you can provide them some stability assistance to support them, but you don't want to give them assistance with helping them with the test itself. This concludes the examination of the lumbar spine. If there are any questions, I'm happy to answer them. Feel free to send me an email at the email address below, and I will give you a prompt response. I hope this was educational and informative, and let's continue to improve the health and safety of our patients.